Hello everyone, sorry not to be with you this year to this congress. I want to congratulate my friends Natalia Cardoso and Sergio Genesiani and all the organizing committee. I'm delighted to be able to give you this presentation with you on the subject of thermal ablation. I will present you an example of radiofrequency ablation. It is the same for the laser ablation. The withdrawal is different, and don't forget your glasses with this technique, but there are lots of similarity. We start by rinsing all the necessary equipment. Here the dilator is mounted in the introducing catheter, the guide is also rinsed, as well as a puncture needle. All this is done with sterile water. Finally, you can see the sterile probe guard for ultrasound and the tubing for tumescent anesthesia. The radiofrequency catheter. Of course, before this, the practitioner is dressed in sterile garments, and don't forget the patient. There is no sedation for the patient. No sedation. It is not mandatory, and it is very important that there is no sedation for the patient. A fundamental step that you will have managed during the preoperative marking session, the puncture sheets, followed by the puncture under ultrasound. Will allow you to insert the guide. The guide will always to be held in the hand to avoid any risk of dropping hand, as with all phlebological procedures. All this will be done under ultrasound. To reduce the pain associated with inserting the catheter, it is easy to use the tumescent liquid and inject it along the guide, creating a sliding space, which will make it much easier to feel the catheter pass through. Then, all you have to do is insert the size 6 or 7 French introducer's catheter. Finally, remove the guide wire and the dilatator. The radiofrequency catheter is then inserted. It is called a catheter here because this device has a space in the middle where another smaller guide can be inserted if necessary to navigate more easily around shorter city or to inject a sclerosant, particularly into ganglion blades or tuberosity, so this catheter will also need to be rinsed. Under ultrasound, the tip of the radiofrequency catheter is positioned approximately 50 mm from the saphenofemoral junction, as you can see here. When we move on to the tumescent anesthesia phase, where the liquid is made up of 500 ml of 1.4 sodium bicarbonate mixed with 20 ml of non-adrenaline 1% lidocaine. This anesthesia is carried out from bottom to top under ultrasound control here in transverse section, but longitudinal section can also be used as your convenience. This is followed by the treatment phase. The patient is awake and constantly questioned about his or her sensation, pain, paresthesia, burning, etc. should cause the treatment to be stopped and the tumescent liquid to be added to the treated area. Here the treatment is done in cycles of 20 seconds every 7 centimeters. This is the hand with the hedged area when you have to stop. Finally, the femoral vein is kept free and the great saphenous vein is occluded. You have to check this by ultrasound at the end of the procedure. A simple compression dressing is applied and the patient is discharged immediately and can go home. In front, we don't use compression stocks. Thank you for your attention. I hope you have an excellent conference in Brazil, and I'd like to take this opportunity to extend my warmest congratulations to this guy as the organizer of this excellent congress, and to invite you to our congress in Paris in November.